In this episode of the Nurse Practitioner Podcast, Dr. Brennan Spiegel discusses COVID-19 patients displaying digestive symptoms. Could you briefly describe your recent work that showed digestive symptoms, including diarrhea, to be common among COVID-19 patients?
Sure. So we know that COVID-19 is principally a respiratory virus. That's where most of our attention has been focused on appropriately, because when people develop shortness of breath or cough or even pneumonia, they seek care because they're having trouble breathing. And regrettably, this can also lead to fatalities. But what we've also been learning is that COVID-19 presents in many different ways, not just with cough, but it can also affect the gastrointestinal system, in addition to other systems. So we've been learning that COVID-19 can get into the intestine through saliva. By swallowing saliva, it gets through the stomach into the intestinal system, and from there, it appears that it can invade the lining of the intestinal system by using the same receptor, the ACE2 receptor, or the angiotensin converting enzyme receptor, that it uses to enter the lungs. That same receptor, ACE2, is found throughout the gastrointestinal system. So it makes sense that the virus could access that system, that receptor, and get into the system. Now, we've been noticing clinically that many people are developing diarrhea and fever. And we're starting to recognize that this can be one way that COVID-19 presents. In one study that I was a co-author on with colleagues in Wuhan, China, we evaluated patients with this form of gastrointestinal COVID. For starters, just looking at people that come to the hospital, we know that about 20% of them have diarrhea upon presentation, usually along with cough or shortness of breath and pneumonia. But there's a larger group of people that don't ever go to the hospital, who are at home wondering if their symptoms mean they have COVID-19. And in the study that I was a part of, we focused on that group of people who had more mild disease. They didn't have critical illness or need ventilators or even hospitalization, but they were clearly having symptoms. And we found a group of patients that had significant form of diarrhea. Some had nausea and vomiting. Some just have low appetite. And this doesn't always occur with cough and shortness of breath. As I said, it can occur totally on its own. So that's an overview of that study, and happy to talk more about the specific findings and the implications clinically.
Does this mean that patients presenting with digestive symptoms like diarrhea should now be considered possibly COVID-19 positive and treated as such?
Yes, it does mean that we need to think more broadly about what a COVID-19 patient looks like. If we're just waiting for cough and shortness of breath, we are going to miss cases of COVID-19. So I happen to be the co-editor-in-chief of the American Journal of Gastroenterology, and we've been receiving and publishing case reports from around the world of people who are coming in just with digestive symptoms and end up getting diagnosed with COVID. So, for example, in a hospital in Long Island, a patient walked in with dark urine. That was her chief complaint. She did not have a fever. She did not have a cough. She did not have shortness of breath. She had dark urine. And on the lab values, it was clear that she had acute viral hepatitis, or at least acute hepatitis. Very elevated AST/ALT levels, over 1,000. Got evaluated for other forms of viral hepatitis, and those were normal. And then after a couple days in the hospital, only then did this patient start to develop a cough. And only then did a chest x-ray reveal that there were infiltrates in the lungs, and this patient was quickly isolated and tested for COVID-19, which turned out to be positive. So in this case, this patient presented with acute viral hepatitis as her presenting feature of this disease. In another case report out of Michigan, a patient presented to the hospital with bloody diarrhea. The patient was admitted, did not have a cough, did not have a fever, did not have shortness of breath, and was evaluated for possible traveler's diarrhea because she had been in Egypt on a trip a few weeks prior. Well, once again, after a few days in the hospital, this patient developed cough, shortness of breath, and a chest x-ray revealed infiltrates in the lungs. Also, colonoscopy ended up finding evidence of hemorrhagic colitis in the colon. So these are two cases, and there are many, many more that we're seeing of patients who are presenting with colitis, enteritis, gastritis, even I've heard of pancreatitis, certainly hepatitis, as the presenting feature. So we're seeing this, and the question is, should we be testing everybody who has diarrhea? Diarrhea is a very, very common symptom in the community. And particularly right now, in the middle of a pandemic, people are under a great deal of stress and anxiety. And stress itself can have effects on the body. It can cause diarrhea. It can cause abdominal pain. It can cause headaches and rapid heart rate and jitteriness and so on, which some people might interpret as being a sign of infection. Generally speaking, just because you have diarrhea does not mean you have COVID-19, but diarrhea plus a fever is a little bit different. That's not just stress. That might indicate something different. And right now, in the middle of a pandemic, if somebody has new onset diarrhea plus a fever, in my mind, that's COVID-19 until proven otherwise. Now, the problem is these patients are not getting tested. And if they do get tested, it's going to be with the nasopharyngeal swab. And unfortunately, that's not always positive. In some cases, in about a quarter of the time, the stool will test positive, but the nasopharynx will test negative. And yet we don't have routine stool testing still in this country, whereas in Wuhan, China, for months now, they've been doing stool testing and finding that it's positive and much more likely to be positive in people who have diarrhea from COVID-19. 73% of those patients end up having positive stool studies, not just nasopharyngeal studies. So there's a lot still that we need to learn. But in the meantime, I think, yes, we need to consider COVID-19 in these patients. And even if we can't test for it, we should assume patients have it, and they should be self-quarantined and monitored.
How would digestive symptom presenting patients transmit the virus since they don't present with coughing or sneezing and release viral particles as aerosols?
Well, this is a very important question, and we still don't have a definitive answer. But there are concerns that COVID-19 could potentially, not definitively, but could potentially pass through stool. So what do we know so far? We know that if we test for genetic material of the virus, so if we're looking for RNA, viral RNA in the stool, it is definitely there. In one study, over 50%, around 54 to 55% of COVID-19 patients in China had evidence of the virus in their stool. And as I said earlier, those with diarrhea in particular, about 73% of them have the virus in their stool. So the virus is definitely in the stool. What we don't know for sure is whether the virus coming out of the stool is infectious or not. Can it cause transmission of the disease if that particle somehow gets on the surface of somebody's body, on their hands, and then ultimately onto their face? We know that this virus enters the body through the nose, through the mouth, maybe through the eyes in some cases. But it's transmitted through the nose and the mouth, the upper airways. How could stool get up into the eyes or mouth? Well, here's one concern. What if somebody has active diarrhea and fever and they're passing the virus through their stool? Well, one concern is that they may contaminate the bathroom environment. They could contaminate they might not clean their hands well, reach for the toilet handle, reach for the toilet paper. And then somebody else sits down on that same toilet, gets exposed to it, reaches for the same toilet paper, reaches for the same handle, maybe wipes their face inadvertently, touches their face before they've cleaned their hands. All these habits, these bad habits that we've learned since childhood, hard to correct that, and have now exposed themselves directly in their face or mouth. Or is there a concern that when you flush the toilet, if the lid is not down, that it could release a plume of bioaerosols into the environment? with bioaerosolized fecal material containing viral particles. That hasn't been proven, but there's a long-standing theory that goes back decades that toilet flush can indeed release a plume of bioaerosols. There's no question about it. And there's always been a concern with C. difficile colitis, for example. Now, hospital epidemiologists tell me that they're not too concerned about that because the particles will fall to the ground quickly and will settle out. But we do know from recent studies looking at the environment around people with confirmed COVID-19 that viral particles are found throughout their immediate environment on all sorts of surfaces, including the toilet bowl. Now, again, that doesn't confirm that we can transmit it this way. And in fact, a study from Munich, Germany that was published in Nature last week is a very small study, but it got a lot of attention. So a small study of only 9 people with COVID-19, and they were not able to find live virus in the stool of those 9 patients. But those 9 patients did not have diarrhea. These were people who had mild respiratory forms of COVID-19. And I'm not surprised that in somebody like that, if they happen to swallow some of this COVID-19 and it works its way all the way through the GI tract, that it's going to be dead on the other end. That's different to me than somebody with active diarrhea who has active colitis and is shedding large amounts of virus into their stool. In that case, I would not be surprised if some of those viral particles are in fact infectious. So I think what this means for listeners is, in terms of guiding patients, if they're sharing a bathroom for at the very least with somebody who has diarrhea and fever, they should be using 2 different rolls of toilet paper. They should be cleaning down the surface of that toilet, cleaning the handle, not touching their face until they've thoroughly cleaned their hands. This is good advice whether we're in a pandemic or not. So that's what we know right now, and I understand there's more research coming out soon to further investigate whether there's really live virus that can pass through the stool. But until we have that, I think we should assume it's possible and behave accordingly.
Since you found that those with digestive symptoms had a significantly longer time from onset to hospital admission, does this present new complications with possible COVID-19 patients being out there without the knowledge that they may be positive for the virus?
Yes, this is one of my biggest concerns about these patients. Now, the good news is that people don't, thankfully, and generally pass away or die from GI COVID. People are not becoming overwhelmingly dehydrated, for example, from the diarrhea, although there is one case report of that so far. But for the most part, the diarrhea is low volume, not seeing significant electrolyte abnormalities from it. So what I'm saying is I'm not as concerned about the clinical course of these patients if they just have GI symptoms. But to me, the bigger concern is, could these patients be unwittingly spreading the disease to other people while they're out in the community undiagnosed? So that's the concern. And in the data from Wuhan, China, and both the study I was involved in and another study also published in my journal, the American Journal of Gastroenterology, both studies found that people who presented principally with GI symptoms were diagnosed considerably later, several days on average later than those who presented with respiratory symptoms. And that sort of makes sense because, as I started with, people don't run to the hospital necessarily because they have loose stools. They run to the hospital because they can't breathe. So naturally, people with primary respiratory COVID will seek care sooner than people who start with gastrointestinal symptoms and only then, or maybe even never, evolve into respiratory symptoms. So the worry is, yes, these patients could be out there, and in fact, I know they're out there because I have diagnosed individuals, including a friend of mine who was very public about what happened. He, in fact, went on CNN and told his story on Erin Burnett on her show. And he's a friend of mine, and he called me up and said, I have fever, I have diarrhea. It's been going on for a week. I can't get tested. I have a family at home. I have a daughter at home who has juvenile rheumatoid arthritis and is on biologic therapies and is immunosuppressed. Could I have COVID? Could I be exposing them? And I said, absolutely, you could. You should definitely be self-quarantined. and you need to get tested, because he's also a university professor. And it's important to know if he's in a school environment, if he got it from students or could have given it to students. And yet he could not get tested. He finally called the mayor of his town to help obtain a test and pleaded for it. And with a great deal of difficulty and almost with some humiliation, they finally sent him the test because he was being so difficult. And of course, it tested positive. Only later did he develop cough, by the way, and he's doing fine now. It took him several weeks, over 2 weeks, to get over the diarrhea that was occurring every day. In fact, we're finding that patients have diarrhea for between 1 and 14 days on average. So yes, he ended up, thankfully, his family has been okay, and he's recovered after about another week of symptoms. But he's just one story, and you can multiply his story by, 1 million. We have no idea right now because we're not doing community-based testing to know.
How do we deal with such a situation from a public health standpoint, in addition to trying to inform the public about these possible symptoms?
Well, this is the big question, is what do we do differently, knowing that COVID can present in ways other than cough? What do we do from a public health standpoint, from a clinical standpoint? I've talked about a lot of this already. One thing that we haven't seen yet that our GI community would very much like to see is the CDC guidelines actively include digestive symptoms among the cardinal features of this disease, and still have not really seen that. Don't know why. Don't know why there's been a reluctance to acknowledge that a large number of people, not everyone, but a good number of people are presenting with gastrointestinal symptoms. I don't know why we haven't expanded testing criteria to include people that we've been talking about today, or why the CDC has not allowed that, or at least encouraged that. There are some places that are doing this now. For example, the University of Michigan. I've been in contact with colleagues there where it's now routine that in the emergency department, at least, the doctors there are sanctioned to test for COVID-19 in people who just have diarrhea and a fever, or myalgias and diarrhea. They don't have to have a cough, shortness of breath infiltrated on the chest x-ray in order to test. That is really important, but we're not routinely doing it. Until we expand our recognition of the protein manifestations of COVID-19, we're going to be missing a giant denominator of patients. And we'll never know until later when we start doing more routine antibody testing, which we're just starting to stand up now. And we go back and we find that these people who had diarrhea, nausea, vomiting may end up having a much higher likelihood of antibody positivity compared to healthy controls who have not experienced symptoms during this pandemic. That's the kind of research that we need to do to inform public health policy around diagnosis and testing, and ultimately minimizing risk of transmission of this disease through modalities or avenues beyond the lungs themselves. So until we do that, we really don't have answers to these questions, but pragmatically, as clinicians, we have to have a low index of suspicion. We have to think about it. We can't think about COVID in every single person with diarrhea. Talked about that before. But certainly people with diarrhea, fever, nausea, vomiting, and who have had a recent COVID-19 contact for sure, or even if they haven't, because it's such widespread community transmission now, needs to be suspected. And hopefully in time, regulatory agencies, CDC, will catch up with the science. But up until this point, we just haven't seen it aligned yet, unfortunately.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.